friends of mine, and I want to take you to my world of craniovertebral junction, to a wonderful world, to a beautiful world, to a world where our surgery will make the difference. The surgery can give new life to the person, completely new life, or it can completely demolish the person. So you give new life or you demolish. That will depend on how much you are trained in this subject. So when a person comes with these kind of neck, he has different problems in the hands, legs. The question is, one, whether you can do atlantoaxial fixation or not. If you do not want to do, or if you cannot do, please do not touch. But if you can do a good operation, you give new life, new neck, new hands, completely new life to these unfortunate people. On the other hand, you do a wrong operation, you completely demolish, finish, and that they will die a miserable death. So it is important that we learn this area very nicely. Craniovertebral junction is a beautiful, it is a miracle of God. It is a magnificent architecture. You see, this is the C1 arch, and see the facet. This facet is the strongest bone of the body. After teeth, they are the strongest in the body. The lateral, the transverse process, the largest transverse processes of the body. Whole spine, this is the largest. There is no spinous process in the posterior arch. C2 spinous process is the biggest spinous process in the whole body. So this is a wonderful, beautiful architectural wonder. This gives flexion, extension, this gives rotation, and there are various, you see there are so many ligamentous mark on the superior surface of the facet. Strong ligaments attach the facet to the occipital bone. On the other hand, if you see this inferior surface of facet of atlas, it is like a naked bone. There is not a single mark of the ligament. So it is the most mobile joint of the body. Atlantoaxial joint is the most mobile joint of the body. Occipito-atlantal joint is the most stable joint of the body. So stability and mobility are the hallmarks, are the premier features of craniovertebral junction. For me, craniovertebral junction instability means atlantoaxial instability. This occipito-atlantal instability is impossible. Extreme rare situation. Craniovertebral junction stabilization means atlantoaxial stabilization. Occipito-atlantal stabilization is absolutely not necessary. So we introduced this technique in 1987, as you know, and many of the people in the audience who are dealing with craniovertebral junction know this technique. But I can also tell you that the indications of atlantoaxial fixation are becoming so wide that everyone should learn the technique of fixation, because I will now discuss the indication. One screw in C1, one screw in C2. We introduced this technique. Now it is one of the most highly cited technique in the subject of spine. So in 1988, I did this first case. You see the bone fusion. Atlantoaxial instability means atlantoaxial stabilization. No occipital stabilization is necessary. Over the period of 32, 33 years, we have done such fixation, selective atlantoaxial fixation in nearing 2,800 cases. My technique since the beginning involves three crucial issues: open the joint, remove the cartilage, introduce bone graft in the joint, and then do instrumentation. None of these three steps is compromisable. You have to open the joint, you have to introduce bone graft. No way you can do remote control fixation. C2 ganglion anatomically is located right behind the atlantoaxial articulation. So if you have to open the atlantoaxial joint, we had initially, long time ago, described that you can cut the ganglion and then the whole facet joint is in front of you, I think. But nowadays, I don't do this technique in majority of cases. But the issue is when we describe this, the whole world of lateral mass became open for surgery. The other important issue in this surgery is the vertebral artery, and I will like to discuss the vertebral artery. So vertebral artery, when it comes from C5 up, 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 then it makes a loop under the facet, under the superior facet. Not so much. This is very much, the loop is much bigger here, but this loop is the one which can potentially injure whilst you are putting the screw. So you have to know this loop very nicely. So we had described in 1988 that you divide into 9 quadrants, and upper 4 quadrants are the safer quadrants, but this is not always true. So this is mobile atlantoaxial dislocation. Your direction has to be medial, your direction has to be superior. As regards C1 is concerned, and as regards C2 is concerned, superior and medial. So this is mobile and reducible atlantoaxial dislocation, no controversy for ages that you have to do fixation. You see this beautiful C2 vertebra, this is the superior facet, and this is the inferior facet. You see, they are not in line. All the other facets in the subaxial spine are in line, but this is here. The superior facet is in front, inferior facet is behind. The vertebral artery comes like this in relationship to the superior facet and then turns out from here. So the vertebral artery is in relation. When you put a screw from here in the pedicle, this area of the artery can be damaged, and this is one has to know very nicely and beautifully. So we introduced this beautiful radio imaging technique and modeling. We made models. You see these kind of models, and this can be held right in the hand in front of you during the operation theater. They are made to size, and you can see exactly where the vertebral artery is coming, exactly how it is rotating, and you can introduce the screw as a preparation before operation. And this is a beautiful imaging technique that we use in more complex cases. So because you see here the superior facet, I showed you here, superior facet, vertebral artery can be in trouble. So you can use the inferior facet. Inferior facet, when the artery is too much medial, you can use the inferior facet, and that can be a beautiful technique. We described this, you see. This is the C1 facet, and you can use inferior facet in high riding vertebral artery. So this is one possible technique that you can use. You see, this is the atlantoaxial instability, facetal instability. The area in the lateral gutter, the bone is quite destroyed. So I've used the inferior facet. This is a wonderful, wonderful technique. The other thing is the vertebral artery loop goes like this, and you have the possibility of drilling and mobilizing the vertebral artery. Like this is the vertebral artery. You can drill the posterior aspect and mobilize and then introduce the screw. This technique is absolutely wonderful technique. Like you see here, the vertebral artery loop is very high. So you mobilize the vertebral artery, and then you see over the vertebral artery, you can introduce the screw. Sometimes you can use transcranial. You see, here the facet of C1 is quite anterior, and to introduce the screw in the C1 can be difficult. So I use transcranial introduction of screw, which is one possibility in cases of little difficult facet of C1. When there is no possibility of other techniques, you can use joint jamming technique. We introduced these kind of spacers for basilar invagination and all those things long time ago, about 20 years ago. We have now started using them very infrequently, but they were first described by us several years ago. When there is, we had also described spinous process screw, spinolaminar screw, laminar screws in this paper in the year 2004. I do not use these screws for a long time. They are not necessary because we have a beautiful C2 pedicle and facet. So this is the spinous process screw that I described in the year 2003 or 2004. So now essentially I do not use occipito-cervical fixation. I use Atlantoaxial fixation. We described for the first time occipital screws in the literature in 1987, but occipito-cervical screws implants are absolutely not necessary. They are, on the other hand, less than optimum kind of stabilization technique. The other beautiful thing we described in the year 2004, 2005, that there is nothing called fixed atlantoaxial instability. You open the joint, mobilize the joint, and reduce the dislocation. Like in flexion extension, there is no change in this odontoid process. The treatment was transoral odontoidectomy. We described the technique of opening the joint, facetal distraction, reduction, and realignment of the craniovertebral junction. Otherwise, transoral surgery was the treatment for these kind of cases. No question, transoral surgery completely historical, and you can realign the craniovertebral junction. Such disruption of in trauma where the facet of one atlas is far away from facet of C2, open the joint, manipulate the facet, and realign the craniovertebral junction. This is vertical dislocation. You see, in extension, it comes down, in flexion, it goes up. Vertical atlantoaxial dislocation we described in the year 2009. When the arch of atlas is broken by bifid like this, there is a lateral dislocation. You see, there is a lateral dislocation in cases with trauma or with bifid arch and lateral dislocation. Now you think as to how you will repair these kind of things, but there is a beautiful technique. Open the joint, distract the facet, realign the craniovertebral junction. Rotatory dislocation, nobody in the world knew how to treat rotatory dislocation, but you can give beautiful smile to these faces if you know the technique of opening the joint and realigning the facets. And there is no question that this is a beautiful technique. Basilar invagination is another complex subject. In 1998, we described this classification. At that time, basilar invagination was considered to be fixed atlantoaxial dislocation. For this group, we described transoral decompression, remove the odontoid. For this group, we describe foramen magnum decompression. Because the entity was fixed, the treatment was decompression. So you remember this, but we completely changed. And now our concept is that entity is unstable and stabilization is the treatment. In this article, we also said for the first time that there is no need to open the dura when you do foramen magnum decompression. In 2004, we described that this group is unstable and this group is stable. For this, you can do craniovertebral junction realignment. Open the facet joint, distract the facet, and realign the craniovertebral junction. So there is basilar invagination. No need to do any kind of decompression from front or from behind. Distract the facet and you can do craniovertebral junction realignment. Now I have got several hundred cases of this kind of treatment. There is no controversy in anybody's mind, and you should not keep any controversy. Transoral surgery is not necessary. Foramen magnum decompression is not necessary. Realignment is necessary. No matter how inside it goes, you can do craniovertebral junction realignment. Instability is the cause. Stabilization is the treatment.
Atul,
So when you see a case with short neck, when you see a case with torticollis, when you see a case with multiple bone fusions like clipal file abnormality, when you see assimilation of atlas, when you see C2-3 fusion, when you see platybasia, when you see dorsal kyphoscoliosis, what is your interpretation? And I will tell you, whenever you see short neck, there is atlantoaxial instability. Whenever you see torticollis, there is atlantoaxial instability. Whenever you see clipal file abnormality, there is atlantoaxial instability. Wherever you see platybasia, there is atlantoaxial instability. So you remember, atlantoaxial instability, you stabilize, and all these features reverse. You see short neck will become long neck, and torticollis will become straight, and this beautiful smile you can introduce this patient. Bone fusions are secondary, never primary. So bone fusion, when you see, you must not start opening the bone and decompression. Decompression is negative form of treatment. When you see assimilation of atlas, when you see C2-3 fusion, your interpretation should be one, and that interpretation is atlantoaxial instability. So this kind of multiple bone fusion, there is no need for any kind of osteotomy. When you see bifid arch of atlas, there is no need to discuss. This patient needs atlantoaxial stabilization, and you will see wonders. You will see absolutely new life to these patients. Even when there is no compression of the craniovertebral junction cord, does not mean anything. You need to do stabilization. This lady was a very influential lady, came with multi-breathing disturbance, and you see the bone fusion. There is no compression of the cervical medullary cord. I did fixation, and this lady got a fantastic breathing in the evening of operation and an absolutely new life. Decompression is not the treatment. Syringomyelia, like I talked about bone fusions and assimilation of atlas, similarly, neural changes. When there is chronic atlantoaxial instability, there is syringomyelia or neural changes. These are secondary, never primary. So when there is syringomyelia, one thing you should immediately think there is atlantoaxial instability, and you stabilize. I want to introduce to you a revolution in craniovertebral junction. Absolute revolution. The issue of central or axial atlantoaxial instability. Carefully see this, and if you can read this, this central instability is a chronic atlantoaxial instability. It is present in basilar invagination, Chiari malformation, syringomyelia, myelopathy related to spinal degeneration, OPLL, Hirayama disease. All these patients have central instability. If you understand this, you can create wonders in the treatment of these entities. Now you see carefully, there is atlantodental interval disturbance. There is a facetal listhesis. This is type 1 atlantoaxial instability. There is dural compression, neural compression. No question, there is a need for fixation, no question. Now you see carefully, there is basilar invagination, severe basilar invagination. There is no atlantodental interval disturbance, but there is facet of C1 is behind the facet of C2. No question, this needs C1, C2 fixation, even when there is no neural compression. Type 3 is even when the facets are in alignment and there is no neural compression, presence of Chiari and presence of syrinx are indicators of atlantoaxial instability, and they need fixation, and the syrinx will disappear. More than that, the patient will get absolutely new life, even when there is no atlantodental interval disturbance, even when there is no facetal problem, there is Chiari malformation, there is no tight cranial posterior cranial fossa, there is vertical reduction in the posterior cranial fossa, increase in the anterior posterior component of the posterior fossa. This patient does not need any decompression, which is a negative treatment. You do atlantoaxial fixation, you create wonders for these patients. Instability is the cause of basilar invagination, and stabilization is the treatment. Several years ago, I wrote about 510 cases of group A and several cases of group B. Both these need one treatment, one and only one, atlantoaxial stabilization, no decompression. So I have no hesitation to say that I have completely demolished transoral surgery, at least from my own department, for several years. And transoral surgery is nowadays considered to be a negative operation. Another beautiful thing I am saying, that foramen magnum decompression for any kind of decompression is a negative operation, is harmful operation. It is not necessary. It is not necessary and harmful. Never do it. So basilar invagination of all kinds, instability is the cause and stabilization is the treatment. All these things are like mother taking care of the child. Nature takes care in chronic situation, basilar invagination. These are bony problems. Chiari malformation and syringomyelia are neural issues. So basilar invagination, syringomyelia, and Chiari malformation are all secondary problem, and that problem is will reverse. So Atlantoaxial instability, the cause of carry one, that to do this operation is difficult. It is not easy. If you want to do treatment, you have to learn this technique. These kind of tonsillectomy, dural removal, and bone removal are negative complete operation, no question about it. So when there is
Atul,
infection, no
Atul, sorry,
Atlantoaxial disturbance, there
Atul, sorry to interrupt you, but I think you missed the message. 5 minutes ago, Vladimir mentioned you have 2 minutes, so we don't want to demolish the.
Okay, no problem. No,
yeah,
no, but just take few slides now. Instead of question, just take 1 or 2 slides are remaining. Can I go ahead? No.
No.
No?
No.
I think you have to, because we have been very strict. We have
problem.
9 presentations, Dr. Atul.
So should I stop?
Atul, thank you very much. It was great.
Okay.
As always, we enjoyed that.
Thank you.
And we now are going to the next.